All right, so thank you for joining us. My name's Dr. Custer and Maya's with me. We'll do intros in just a few moments. This is the Wayne County Health Catalyst for COVID Care, health literacy training. So we do have a pre-session evaluation that we would love you to fill out if you could. You can either scan the QR code or Maya put the link in the chat box. Thank you, Maya. If you're joining us online, the link should be listed below the module. So we'll give everyone a few minutes. Okay. All right. So welcome everyone to the Wayne County Catalyst Health Literacy Training. I'm Dr. Carolyn Custer. I put together this health literacy training with Maya Campbell and basically the director of this piece of the project. And I'll let you go.
Hi, good morning. I apologize if there's any background noise. Where I am, if there's a little construction going on, so I apologize. But my name is Maya Campbell. I'm the registry and membership specialist at Mishwa, and I'm also a proud CHW. So thank you for everyone participating this morning.
All right. And before we get started, we do want to tell you this is an interactive or meant to be an interactive or engaging conversation. So we're looking forward to any feedback or ideas you might have. All right. So we're going to go ahead and get started. Okay, so our agenda and overview of health literacy. We'll go through 5 interventions that can improve health literacy. We'll take a short break and then come back to speak about specifically strategies to overcome vaccine hesitancy, and then an interactive case discussion if we have time. The learning objectives are really understanding how health literacy is a determinant of health. There are some strategies that we're going to review to address health literacy, specifically class, culturally and linguistically appropriate services, and reflect on strategies for culturally competent care. And then we'll talk a little bit about vaccine hesitancy. If you have any questions or comments, please feel free to put something in the chat box. Maya will be monitoring it, or you can even raise your hand or just come off mute and talk. All right, so health literacy, you have to start with health equity. So let's go over health equity. Do people recognize this image of the difference between equality and equity? I see Donna nodding. So, we've seen this image a lot. This is, trying to reflect the difference between equality and equity, right? So equality is everyone has the same opportunity. But you can see with equality, that doesn't necessarily mean that everyone's going to succeed, right? So equity is giving people what they need to succeed. But we're going to take it one step further. So the next step is justice, and this is where we're at, and this is what we're doing all this work for, right? So how do we break down those systemic barriers that cause the inequity in the first place? So health literacy in the context of health equity is really the lens of what we're going to discuss today. Social determinants of health. I think a lot of you are community health workers and familiar with this concept. Just remember, social determinants play a large part in whether a person is healthy or has health, right? So these are the things that you place, kind of where you live, right? It's placement. So where you work, play, live, what's the context? What's the community like? What are the opportunities? Social determinants are all of these things. And so that is really where we're going to start. So I'll turn it over to Maya.
Great, thank you so much. Okay, I just want to make sure my audio is okay. Can you hear me okay? Okay, excellent. Okay, so health disparities. So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by socially disadvantaged populations. These things do exist because inequalities and factors like social determinants of health and systems that are designed with structural racism. All right. So health literacy in Wayne County. So as we know, unfortunately, Wayne County was what we called red line. Is anyone familiar with that term? Does anyone want to come off mute and discuss what their understanding of redlining is?
Anyone want to take a stab?
Okay, I'll take a stab at it. It's my understanding that redlining usually separates a particular economic and racial separation in maybe a county or city or townships or something like that, where they separate certain cultures, ethnicities, and economic brackets. My understanding.
Absolutely. Thank you so much for that. So you're absolutely right. It does separate or make it difficult for certain populations to have access to things like healthcare and education. So thank you so much. Okay. So what does health literacy mean? So what is anyone, I'm sorry, I know I just asked, does anyone else want to come off mute and discuss what their definition of health literacy is, or their understanding of what health literacy it means?
What is health literacy? Okay, I apologize. I was clicking through you.
That's okay. So health literacy quite literally means your understanding of health. So Dr. Custer, do you want to talk about Healthy People 2030?
Sure, thanks, Maya. So every 10 years, we put out this Healthy People, and there's goals, right? And the goals are to improve the health of America. And traditionally, health literacy has been a piece of this because we knew and understand, we've known and understand, right, that if people don't have the ability to use the information or understand or find health resources, that could limit their health. However, in 2030, they added organizational health literacy. And so this is the degree that the organizations, or our organizations, equitably enable people to improve their health literacy, to find those resources that they need. So it's not on the person. It used to be like on the person. Now it's on the person and us as providers to make sure that our practices and what we're doing are helpful, right? So that's a lot of what we're going to talk about today. And I think I'm turning it back to Maya.
Yes, thank you so much. So some health literacy components that we want to discuss, the skills and knowledge needed to interpret health information. So it's the literacy, the reading, writing, basic math, and speech. Numeracy, so that's the understanding of how numbers are used in the real world. Some factors that impact health literacy are the complexity of the information, the language, is there a language barrier, the age of the patient, or the state of their health while they're at the appointment. Are they anxious or nervous, or are they really sick? Cultural background. So the way that health information is communicated by the provider is another factor as well. Okay. So this is just a breakdown of the individual and system factors. So the individual factors are, of course, the literacy skills, the health knowledge, demographics, culture, and experience. And on the systems or professional factor side is public health practice, public health infrastructure, and public health workforce. All these things together make up health literacy.
Okay, so what are some of the impacts? Oh, thanks, Maya. What are some of the impacts of limited health literacy? People with limited health literacy are less likely to use preventive measures, and that makes sense. They're not aware of them. Less likely to effectively manage chronic disease. Chronic disease management, as most of us on this call know, requires a lot of different steps. More likely to have poor medication adherence, higher rates of hospitalization and use of emergency, higher mortality rates. This one's a big one that we'll talk about again, but reporting a sense of shame about their health literacy. This idea of shame can cause patients or members or clients to maybe not open up and, ask questions. And we're going to talk about that. How do we get people to open up and ask questions? Associated with higher healthcare costs and expenditures. So on a community health literacy level, Some of the things that can be impacted: missed opportunities for services, vaccines, preventive screenings, preparation for emergencies, weather disasters, environmental warnings, and public health, food safety. So these are just some examples. You can see that having a limited health literacy on an individual and a community health level can impact just opportunity for health in general. So health literacy and literacy, the average reading level of adults in the United States is 8th to 9th grade. However, most of the health education materials that we have available to us are 10th grade level or higher. So that presents a problem with understanding. So the best, I put best in quotes, reading level is 5th to 6th grade. And we'll talk about that a few times, writing things in plain language, not using medical jargon, etc. So aim for the 5th to 6th grade. Red flag behavior when you're with your member or client and they display, this kind of behavior, it could be a red flag that they have low health literacy. Things like missing appointments, not being able to fill out forms, non-compliance with medications, asking fewer questions. This goes along with reporting a sense of shame. If, docs or providers telling a patient, here's your course, here's your treatment plan, and maybe they're just nodding, right? Okay, and then they say, do you have any questions at the end? You say, no. That can be a red flag that that person maybe has a lower health literacy and isn't understanding what you're saying. And lack of follow through. So these are just some behaviors to note. All right, so using a universal precautions approach. This comes from the AHRQ Health Literacy Toolkit, which is available at the end of this presentation. There's links for all the slides and everyone will receive them. So, bloodborne pathogens. Who knows about bloodborne pathogens? Probably everyone. Basically, remember when HIV came out and there was in hepatitis, you can't tell if someone has HIV or hepatitis, for example, just by looking at them. You can't tell by their job, you can't tell by their education level. So we treat all blood spills as potential bloodborne pathogens. That's called using a universal approach. So no matter what blood we see, if it's blood, we use a specific way to clean it up. We use, our gloves or whatever protective gear. And just in the same way, you can't assume a person's level of health literacy just by looking at them, just by their education level or by their job. That doesn't translate. So a universal precaution approach just assumes everyone has low health literacy or limited, and it forces us to communicate in a way that people can understand better. And really using this approach is, it simplifies communication, confirms comprehension. It reduces the risk of miscommunication, which makes, the healthcare system easier to navigate. And we want to support our patients' effort to improve their health. So we're going to talk about ways that are just ways to implement a universal precaution, assuming everyone has low health literacy. The more we normalize, the less we stigmatize. Okay, so this I'm not going to go through, but this is what a health literate organization looks like. And we talked about what can we do on our end, and some of these things we're going to go over in just a moment. But it's important to note that to be considered health literate, it has to come from the top, and it has to go into all the operations and planning of the organization.
Okay,
So,
so
is someone questioned? Okay. So these are the things that we're going to talk about a little bit and just be familiar with. Okay, I'm going to turn it back over to Maya.
Okay, thank you. So this is another interactive moment. We love these. So does anyone have, or what does anyone want to share a story or something that they have regarding a family member or loved one having low health literacy and how it impacted them? It could be a family member, or I know there's CHWs on the call, so even a patient or a person served that you've worked with. No one wants to share? Okay. So I can definitely share. Again, I am a very proud CHW. I can vividly remember clients coming in and uh, we would ask them questions regarding how they felt about their medications, and they would still have like full bottles of medication. So they would explain during the appointment that they didn't understand how to take the medication, so or they were just taking it once a day when some of the medication may have called to be taken twice a day. But because they had lower health literacy and they really didn't understand the information during the appointment, they were taking their medications wrong. Has anyone, really quickly, has anyone ever had that experience while working as a CHW?
I could share. Sometimes it's not so much that they don't know how to take the medication. I've noticed that some of our patients don't understand the role of the pharmacy or how the pharmacist plays into their medications. Like every time they need a refill, they call us. They assume that they have to call us every time they need a refill, as opposed to they don't understand that some of the medications were sent initially with 2 or 3 refills, and they should be contacting the pharmacy just to have them refill them and asking them. Of course, a lot of our patients seem to be I don't know if the word is transit, but their phone numbers are very transit. They change phone numbers often, or they're out of service. And sometimes I have to tell them, hey, when you receive a script, look and see how many refills you have. Once you fill the first one, you can call the pharmacy, not us, to have that prescription refilled. And if you keep your number, accurate number on file with the pharmacy, they can either do auto renewal refills, or they can text you when things are ready for pickup. So it seems to be a huge disconnect in that area that I've observed lately.
Thank you so very much for sharing. I absolutely love doing these trainings because every time we do one of these trainings, we hear a different perspective. So that was definitely a different perspective, but thank you so much. And you have some really good points. We'll definitely touch on some of your points later in the training, but again, thank you so much for sharing.
I was about to say that, Maya. Okay, great. Anyone else?
For me, can you guys hear me?
Yeah, go ahead.
Yes.
So when I help our clients apply for Medicaid, I tell them how important it is to, submit all the documents that they're being requested, and they just, seem to just, nod their head, yes, yes. But once they come back to me, like the letters are overdue, or they're wanting to apply again, and like they don't really like hear it, like it comes from one ear and then comes the other one. They don't really like understand how the importance of like it is to like keep in up to date to the letters and stuff.
Mhm.
So it's something I struggle with. I try to be the most tell them how important it is, but sometimes it's hard for them to understand.
Mhm. I mean, Medicaid navigation is probably one of the most health insurance navigation period, right? Understanding that is quite complex. Thank you for sharing.
Absolutely. Thank you so much. Today is beautiful. Like we're getting so many different perspectives. I'm in love today. So, okay, great. Thank you. We'll go on to the next slide.
And I think there was a chat. There's something in the chat, Maya.
Oh, I'm sorry.
No, that's okay. Oh, it's Michelle. Healthcare cost is too expensive. Many individuals undergo seeing their providers. That's a whole nother level, right? Of system policy change that needs to, yeah, that's true.
Absolutely. Thank you. Thank you so much for the information. Okay, so health literacy intervention. So these are strategies that increase the client's health literacy level and creates a more health literate environment. Okay. So the first health literacy strategy we want to talk about is clear communication. So greeting the patient warmly when they walk into the office, making eye contact, using the patient's words. So that lets the patient know that you're engaged in the conversation, slowing down, showing graphics. Graphics are a great way to demonstrate how a procedure is done. I'm a visual person, so I love graphics. Okay. Listening carefully, limit and repeat content, invite the patient's participation in the conversation. Use plain non-medical language. That's a big one. Be specific and concrete and encourage the patient to ask questions. All right, so 7 things to consider when communicating about health. Trust. Will the person trust the information that's being provided? The information is what's being provided. Is it necessary? And how much is too much? Information overload is certainly a thing. Motivation. How relevant is the information to the person that is trying to reach? I think this is, do you want to split this slide, Dr. Custer? Okay, so the environment, what are the conditions that surround and affect the audience? Capacity, does a person have the ability to act on the information? Their perception, what will they think of this information? And the response, how will the patient respond? And what can you say to encourage them and support them to take action?
All right, thank you, Maya. All right, so using plain language, you guys are community health workers, you know a lot about this, but certainly we want to avoid medical jargon, right? It can certainly confuse people. These are just some of the different, instead of try saying, the one that I wanted to highlight, and I do it every time, is the word diet. So if you ask a patient or member, what is your diet? They are going to come back and think, are they asking me like Weight Watchers or Atkins or, Jenny Craig? And there's a lot of diets, right? But in fact, we're asking, what do you eat? So, just be mindful about the words that you use. Another example is the word adverse. It's better to say the word bad. All right. Your COVID test is positive. So at one point, I don't remember which screening, but we were at a screening for COVID test, like a fair. And we told someone that their test was positive and they thought that that was a good thing because positive is a good thing, typically. So we changed what we were writing to you have COVID or you do not have COVID because it's fine. We're writing exactly the most direct message. And that's the point of this. The more direct the message, the easier it is to understand. All right, so clear communication is always a key, no matter where you're at, right? No matter what you're doing. The second strategy that we'll discuss is effective health education materials. So a few quick points. Making sure your materials are easy to read and understand. You can check readability if you write the thing yourself, aim for 5th to 6th grade. The purpose of the material is clear, right? So there's not irrelevant information. Using common everyday language, stuff with medical terms or large, jargony words you should avoid. Materials broken up into chunks, right? So if you see a handout and it's all words all the way down, yeah, nobody's going to want to read that. Break it up into chunks, use graphics to kind of demonstrate the key message. Good materials identify at least one action item. So why are you even looking at this flyer? Are you trying to influence, are they going to get their vaccine? And we'll talk about that in just a minute. And then be aware of confusing numbers. So what we're going to do now is we're going to open it up to you guys. We'll actually show you some health education materials and we'd like your feedback. So please feel free to come off mute and give us your feedback. So here's 3 flyers. They're a little bit small, but they're all related to vaccinating kids. The one on the left is MDHHS. The one on the right is CDC. And the one in the middle is Authority Health. And I love that flyer. So when you look at these 3 flyers, thinking about what we just said for being an effective health education material, which of these 3 do you think is the most effective and why? And there's no wrong answers. So if you're a parent and you're looking, which one of these do you think would move you? If at all, I guess. Brittany?
Yes, okay. Well, I work for Authority Health, so I know I'm not biased, but I am a little biased. But this Authority Health one is very straight to the point. It's cute and it gets directly to the point. Whereas the one on the right, it, takes a little bit of reading. You have to, you know what I mean? So I would say the most effective one would be the one in the middle.
Would anyone else?
It looks like we have something in the chat
Cute mom
from
and
Michelle. I'm sorry. Michelle saying the second picture, the cute mama and cub.
Right, so if we talk about the message, the main message, keep your cubs safe. Like every parent can relate to this, right? Keep the school year fun going. What does that mean? No, I'm just kidding. But it's not as clear, right? Keep your school year fun going, keep up to date.
like school about to start back.
But what does that mean? What do we do, right? And then the one on the right, Brittany, I agree. Too many words, it is the best way to help protect children, but this is just more direct. Okay. All right, let's look at this one. So this one came out and MDHHS put this out and they did it in a bunch of different languages. So my question is, if you look at this, scientists have taken hundreds of steps to open the store. So this picture here, number one, and number two, things like decades of research, clinical development, scientists, doctors. What do you think? Would this work with your member or patient? Would this be effective? Do you think they would? What do you think about this?
You know what? I would say this, just like the third, let me see, what was it? The picture on the right for the we just got off of. I'm the type of person who likes to read instructions, so this is good for me. But if you're not an instruction reading person, this is already too much to start with. And then, like you said, the jargon. People don't care about how many tens of thousands of diverse. First of all, some people like, what does diverse mean? Volunteer. We can dissect this 100 different ways. Decades of research. I hate to say it. Some people may not know how much is a decade. So it's already a lot. It's a lot. I like the open door concept because people know that we were shut in because of COVID, but I don't think that it, I think the best way I want to word this is just like when you watch, what is it? Medication commercials on TV. They're designed for the physicians, not for the laymen.
Right,
And
absolutely.
most of the time, those are the ones who don't even have access to it. So I think this is more written from the perspective of the educated as opposed to help educate.
Thank you for sharing. That's great
Yes,
feedback.
and yes, absolutely excellent feedback. We have a chat from Rosalia. I'm sorry if I mispronounced your name. Rosalia said too much information they see and they may not understand and be too shy to ask. And Michelle says that she agrees with the person that was speaking. Yes. Thank you.
Thanks, Maya. Okay, so the next few are all MDHHS. And so the first one's about the Omicron booster. I'm bringing this up to show you that there are multiple asterisks and there's fine print underneath. Anytime you have any kind of asterisks with fine print is going to cause, it could potentially cause confusion, right? So in the same kind of sense, and everyone probably can relate to this causing confusion, how they came out and said, okay, this is what you have to do if you test positive, right? And there's multiple asterisks again, and you can see all this small print. And I share every time. I received a call from one of my girlfriends and she said, my daughter has COVID. It's day 6. She still has a fever and cough, but her boss wants her to come back and wear a mask. I said, no, she has symptoms. So if she's symptomatic, she's not supposed to be leaving, right? So it was just confusing. A lot of people were confused by this. Any thoughts or comments on these two? Okay, let's look at this third one. Make a COVID-19 plan. So this was, I think, a little bit earlier, but you can see here, they have these large points that are pretty important. What do you think about all these small points on this flyer? Do we need all these extra points?
They're pretty difficult to read.
What do people think if this flyer just had the big checks with the big font? Would that be a more clear message?
Yes, I think it would be a clearer message, and then maybe the link where it says learn more about vaccines. So if they are questioning, well, the details, they can actually, go to that website.
Yeah, that's a great suggestion, actually. Or even a QR, well, no, because QR codes not everyone's into, right? But okay, any other thoughts on these three?
I think this last box on the last one, therapeutics, people don't know what that is.
Oh, yes,
That language is too.
absolutely. I usually don't see the therapeutics because I have all of you over it. You move you back. Okay, so we're going to move on and I'm going to turn it over to Maya for the next two slides.
Yes, so we're going to go through two more slides. So I just want everyone's feedback. If we take just a moment to look at this flyer and consider the population served. What is our initial feeling when we see this flyer? So we think about maybe a parent taking their child to a doctor's appointment and this hanging in the office. What would be your feeling? Kind of scary, right? Yeah, lots of words. Sylvia, thank you. There's a baby crying, there's someone in a hospital bed. This is really scary, right? And it's lots of small words like we talked about before and all packed together.
Keep the kids safe.
Yeah, so we can definitely pull that from the flyer, but it's a little scary, right?
Yes.
Definitely not on the average on the possible reading level that you discussed earlier. And again, just too much information.
Sure.
Mhm.
So let's take a look at the next one, if we can go to the next slide. Okay, so how do we feel about this flyer? It's not as scary. There's no one in a hospital bed. There's cute little cartoon graphics, but there's a lot of information here, right?
Right, like Ms. Burrell said, it's
Oh,
too much information.
Yeah, and Sylvia in the chat said there's small font. Absolutely. So the last two flyers actually, too much reading information, Rosalie said in the chat. The last two flyers actually have the same information. One was produced by MDHHS and the other by the CDC. But these two flyers actually do have the same information.
All right. So let's move on. Oh, Maya, you have one more slide.
Oh, I'm so sorry. So using health materials. So when using health materials, don't assume that your patient can read the materials. And when reviewing a handout, because to be honest, as a CHW, when we're out in the field, sometimes the information that we have is just the information that we have. Those are our tools that we have. So sometimes we only have the flyer from the CDC. So circling and highlighting the most important information does help with that. And personalizing the information by writing the patient's name on the flyer or the information, the pamphlet, and also adding any medications, things like that. I'm using Teachback. Teachback to confirm understanding. We'll talk more about Teachback here soon. And emphasize the importance of keeping the material so that the patient can refer back to that if they have any other questions. Another key point is we want to make sure when we're referring those digital sources, instead of just saying, hey, check the CDC's website for the most up-to-date information, we want to make sure that they actually have access to the internet when doing that, and obtain the patient's feedback on the materials that we're sharing with them. Thank you.
Thank you, Maya. All right, so we're going to talk about Teachback as our next and third strategy. Studies have shown that 40 to 80% of the information that we tell our patients is forgotten, and half of what's remembered is incorrect. So it's really important that we are using clear communication. And Teachback is a great method to help confirm that the patient has understanding. Has anyone learned about Teachback? Okay, so I'm going to say this multiple times during this session, but just note that we're going to do a quick, brief overview of Teachback. This is something that you'll need more exposure to if you want to practice it. YouTube is a great resource. So what is Teachback? It's a way of checking understanding by asking the patient to explain back in their own words. It's a way to make sure that you explain information clearly. It's not a test or quiz. You're not like pimping the patient. You just, you're explaining things and asking them just, hey, just let me know, what did I just say? So why is it important? Like we just talked about, it has been shown to improve patient understanding and adherence, decrease callbacks and canceled appointments, and improve patient satisfaction. So elements for using Teachback, these are kind of the elements that you're going to use for any communication or method that you're using. Using a caring tone, right? Displaying comfortable body language, using plain language, using reader-friendly materials. So how do you do it? You use non-shaming, open-ended questions, ask the patient to explain back, and emphasize, right, that it's my responsibility to make sure that I'm explaining things clearly to you. So the responsibility is on you as the provider, and make sure that you document that. So here's a quick graphic on how to do it. Of course, if your patient has multiple conditions, let's say they have hypertension and diabetes and COPD, you're not going to want to tell them all about hypertension, diabetes, and COPD, and then ask them to explain back what you just said, right? So you have to chunk things up into smaller portions. And then you just ask them to teach back in their own words. And if they can, that's great. If they can't, then we try to word it a different way, right? Or reteach using maybe a handout instead. And then you just keep going. So what we're going to do is Maya and I are going to do a reenactment of a Teachback example. I will be the provider and Maya will be the patient. And the next 3 slides are prepared to represent like a handout, right? So just bear with us as we go through it. Okay. Mrs. Campbell, as you know, your COPD and diabetes put you at higher risk for developing severe COVID-19. I'm going to prescribe the antiviral medication called Paxlovid. This is what a dose of Paxlovid looks like. There's 2 pink pills and 1 white pill in each packet. You need to take the whole packet 2 times a day for 5 days. Here's some additional information about taking Paxlovid. I've highlighted the most important instructions, such as swallowing the tablets whole. And here's a list of medications that you need to avoid when you're taking the Paxlovid. Do you recognize any of these? Are you currently taking them?
Yes, I do. I take St. John's wort daily.
Okay, so we'll make sure and avoid the St. John's wort while you're taking Paxlovid. Here are some side effects to look out for. The most important thing is liver damage, and you can, if you experience any of these symptoms, loss of appetite, your skin turning yellow or itchy or dark urine, please make sure and call us right away. And these are some other common side effects. These will resolve within 3 to 5 days. Okay, I'd like to make sure I explained everything clearly to you. Can you please tell me how you're going to take Paxlovid and what to look out for?
Okay, so each pill packet has 3 pills. I might need to take 1 packet 2 times a day for 5 days. I avoid taking my St. John's wort while I'm on the medication. And I can't remember what side effects to look out for.
Liver damage is the big thing.
Oh, that's right. Okay, so if I notice any changes in my skin or my eyes turning yellow, or if I get itchy or my urine gets dark, I'll be sure to give you a call.
Okay. So that was a very simplified, quick example of how you could use TeachBack, but the main things are you can use your handouts. Imagine this was a handout that we were using. She can refer back to it. So I would point to liver problems. And that's something. And so please feel free to look for more modules on TeachBack or more examples on YouTube because it's a great method. All right. So that was a quick intro to TeachBack. Health literacy strategy 4 is small steps to health. This is not necessarily, well, not necessarily evidence-based, although I think there's probably enough research now nationally. Authority Health, while I was there, I directed community medicine. And one of the projects we did with the residents was in a laundromat. We did increasing health literacy. Every single Saturday, I went with them, a different resident would go and we would teach, right? We would just teach people in the laundromat. And it was a great experience. We used a lot of different continuous quality, we were constantly tweaking what we were trying to do. Unfortunately, the pandemic kind of put a stop to that project, but we shifted gears and we came up with the small steps to health instead, which was planned to be at a laundromat near Narden Park. So small steps to health, there were 5 main conditions that we were targeting: high blood pressure, diabetes, physical activity, nutrition, and stress. And the whole point of it was small step behavior change. So we had cards, we have posters to put up, and they all were discussing in the context of those 5 conditions, what are some small steps that they could take, right? So let me give an example. Adults are supposed to do 150 minutes a week of physical activity. It's funny because I now work in a different medical setting and I audit, and I see in the chart recommended 150 minutes a week of activity. And like, that's not a recommendation, right? That's huge. How does that happen? So instead of giving a really large goal, work with the patient to identify something small they can do. So, if they say, I can't do that, doc, there's no way I can do that. I can't walk outside. For example, maybe they can't walk outside because of the weather, right? What can you do? So maybe you can put a YouTube video on in your kitchen and dance for 5 minutes. Maya has a great example of what she did to become healthy. Do you want to share that?
Yes, absolutely. I'm sorry, my other device fell over. I hope I can get it stable now. But absolutely. So what I did, I'm still continuously on a health journey. But during my health journey, I wanted to get more physically active. So one way that I would do that, I love Law and Order. So if my treat to myself, if I had the opportunity to watch Law and Order every night, I would walk in place for the entire show. So that means that's 60 minutes of continuous movement, just to get myself off the couch. So I just retrained my brain to say, every time I watch Law and Order, I have to walk in place. And that's a small thing, but over time, it made a huge difference. And that's a lot of steps, 60 minutes of continuous movement. That's a lot of steps in one day, considering, my previous of, just sitting there watching TV. So no steps at all. So, yeah.
Thank you, Maya. Another thing is, increase your water or drink more water. That might be hard if people don't drink water like me. It might be something like, hey, can you drink a glass of water before your coffee in the morning? Something like that, just to introduce something specific and concrete to introduce a way to start the behavior change. So any questions on that? Just so everyone knows, we partnered with Libraries Without Borders, and they're a great organization if anyone's interested in doing health literacy work. Robert?
Yes, I have something to say. What the young lady just was talking about, Miss Campbell. My doctor also told me the same thing. He said, Robert, you have to exercise. He say, try to, like, when you watching TV, walk around or something. He said, when you get off work and go home and just sit on the couch and go from the refrigerator to the couch and just sitting down, that's not healthy for you. He said, your legs, you have to move. So that was very interesting what Miss Campbell just said. So now when I go home and when I'm watching the movies or sports or something, instead of sitting down, I can actually refer to what she just said, stand up and move around, because I'm always sitting down. And then I told him that, like, the back of my legs was hurting. He say, well, Robert, that's why. He said, your leg, you're getting older. He said, you're not young as you used to be. So while you sitting there on the couch, he said, that's why you having aches and pains, because your body, you have to move. And that was very interesting what Miss Campbell just said. I'm gonna use that.
Great, great. And thank you so much for sharing that. And it really is a small thing, but when we think about it, if we go home in the evenings and even watch a 30-minute show every night, if we walk during those 30 minutes, that's 30 minutes of cardio. So yes, thank you so much. I appreciate that feedback.
Yes.
All right, so we'll move on to our fifth intervention, which is the meat and potatoes, and I'll turn it back over to Maya.
Thank you so very much. I'm sorry, it just got a little noisy in my background, so I do apologize. Okay, so health strategy number 5, consider language and culture. So fortunately, Wayne County is a mix of different languages and cultures. That is the beauty of Wayne County. So with knowing that there's different cultures that we do live in this or work in this melting pot of Wayne County, it's important to know and understand the population that we're serving. So we'll review CLAS or CLAS. Okay. So CLAS standards CLAS stands for culturally and linguistically appropriate services. And this is the framework to deliver healthcare services in being respectful and responsive to the patient's cultural beliefs, preferences, and communication needs. And using CLAS standards does promote health equity and promotes health equity and reduces disparities. Okay, so the CLAS themes are the principal standard, the governance, leadership and workforce, communication and language, engagement, and continuous improvement and accountability. All right, so some strategies to implementing CLAS. The first one we'll talk about is language-related strategies. This access language preferences and language assistance needs of the person served, the patient, or the member. Use acceptable language services. And don't use things that are not don't use the things that are unacceptable. We'll talk a little bit more about that in the next slide. Plan for interpreter services in advance. I do like to share, as a CHW, when I worked in a clinical setting, what I would do to prepare, I would look ahead. So I would look at tomorrow's schedule and see who's coming in and plan those services accordingly. Provide written materials in the patient's preferred languages. Some culturally related strategies: respectfully ask the patient about their health concerns and customs, avoid stereotyping based on religious or cultural beliefs, and acknowledge and address implicit bias. All right, so some language translation services do's and don'ts. So you do want to use the bilingual clinicians or any staff members whose proficiency has been confirmed. You want to use staff who are trained as interpreters. You want to use on-site medical interpreters if they're available, and also telephone medical interpreter services. You do not want to use clinicians whose proficiency has not been confirmed, or people who are not certified medical interpreters. This is a big one. You don't want to use the patient's family and friends. While working in the clinical setting, I know that was very common. A family member would bring in a son or a daughter. We don't want to do that because it does pose an issue with the patient's privacy. And you want to respect their choice to have a quality interpreter present. And we absolutely don't want to use minor children as interpreters as well. Okay, I'll pass it back over.
Thanks. And this point is, if they insist on having a family member, respect their choice, but also bring in an interpreter. right? Okay. So University of Michigan has a website. I've listed it at the bottom of the slide. It's called the M-Care Guides. They took a lot of effort and looked at different health education materials, and they have things available for most diseases and conditions and in multiple languages. So you can see all these languages. Some of the stuff they've written themselves at a 5th to 6th grade level, and some of the stuff they've curated from other orgs, but they are at the 5th to 6th grade reading level. Some of the stuff is just information that they've written out in the 5th to 6th grade level, but you can take that and use it however you need to use it. So I encourage everyone to look here if you want to see some plain language. Of course, we're talking about COVID, so MDHHS has different flyers that are in different languages available. So we just wanted to point that resource out. The link will be at the bottom of the slide. All right, so we talked about language. We're going to move to cultural competence now. I'm going to move you guys so I can read. So cultural competence is really important. We know that religion, culture, beliefs, ethnic customs can influence how patients understand health, how they take care of themselves, how they make decisions. So having cultural competence relies on the principles of trust, respect for diversity, equity, fairness, and social justice. All the things that we've kind of outlined during this presentation. Considering culture can help us, right, to make better decisions, to engage patients better, and to make treatment plans that are consistent with the patient's values. So how can culture impact health? These are just a few examples of how culture can influence health behaviors. So health beliefs, right? In some cultures, people believe talking about a possible health condition can cause it to happen. Health customs, some cultures, family members play a large role. For example, there might be elders in the family that make the decision. Roles of women and men may determine who makes the decision about accepting and following through with medical treatments. Religious faith and spiritual beliefs may affect how people use healthcare, so or the willingness to accept specific treatments, right? Dietary customs, this is important when we make recommendations to change people's diets. Are they even familiar with cooking, right, or preparing what you're proposing, a DASH diet? If they don't eat that food already, then you may need to do some cooking classes or whatnot. Just something to consider. And interpersonal customs is a big thing, right? So make sure you know with your population served, is eye contact or physical touch appropriate and expected or not? Different populations have different interpersonal customs. Sometimes even showing the bottom of your shoe can be offensive in some cultures. So it's just really important to learn the population that you're working with. Okay, so the next few slides are pretty heavy. They go through some pretty big concepts. You could, take a whole semester course on some of this stuff. So I encourage you, we're going to bring them up and introduce them. If they're not familiar to you, I encourage you to look further into them. Addressing implicit bias. Implicit bias is something that's kind of a buzzword. We want to make sure that we all have looked at our own, looked at ourselves and I'm having a brain fart. Make sure, look at our own.
Understand.
Oh,
Just on like Google Drive.
Oh, I'm sorry. Can someone mute? Okay, so we all grow up in different families, right? Different places of the world, different beliefs. Our worldview, everything that we grow up and learn, that's kind of like what forms and shapes our view of the world, our worldview. So it's important for us to understand that and understand that the things that we believe, may be biased. And so, looking at your own, you have to reflect, right? And understand that. All right, trauma-informed service. Has anyone heard of toxic stress or adverse childhood experiences? Okay. So we understand how trauma and toxic stress impacts the body. Toxic stress is when we talk about, we know the stress response, right? The fight or flight feeling that people get. Imagine that you're in such a stressful environment that that fight or flight feeling doesn't go away. And your cortisol levels and whatnot are elevated consistently. Stress hormones need to come back down to steady state. You know, they're not meant to be elevated consistently. And that can impact the body over time. So that's what we're talking about. We're talking about how trauma impacts the body and health. This, I don't know if anyone's read The Body Keeps the Score. Has anyone read it? Want to come off mute? Okay, so everyone has a reading assignment. The Body Keeps the Score is it's dense. It is an amazing book that really goes through and explains how this has happened. And Bessel van der Kolk is a psychiatrist. He's very old. He's been through the last 60 years. He's been active, so his perspective is really interesting. So I'll just put that out there. Okay, I'll let Maya come off and talk a little bit about Maslow's hierarchy of needs.
Yes, thank you so much, Dr. Custer. So I'm pretty sure we're all familiar with Maslow's hierarchy of needs. Of course, the needs at the bottom of the pyramid have to be addressed in order for an individual to move up kind of the pyramid toward the top of the pyramid, which is self-actualization. I like to think about my time as a CHW during COVID. There was a huge push during COVID for mental health, which I'm pretty sure we all can agree that there was definitely a need for mental health before, during, and now after COVID, but certainly during isolation. But as a CHW, of course, we wanted to push that for all of our patients, but we had patients that came in that were going through eviction or lost their job. So it's difficult to talk to someone about self-esteem and love and belonging if they don't know how they'll pay their rent or if they'll have food for that night. So that's just something to think about. So I'll pass it back over to you, Dr. Custer.
All right, thank you, Maya. All right, the pair of ACEs, so adverse childhood experiences. This comes from George Washington University, Dr. Dietz's model. So we know adverse childhood experiences can impact health, but we have to solve these in the context of the community environment. So we are charged with or tasked with system level changes, right, that address these adverse community environments so that everyone can have health, right, equity. So this is just an overview of the things that our populations are going through and where we need to really focus efforts. If anyone has any comments, please let us know. This is our last slide before the break. I do a trauma-informed service presentation with graduate students, so like nursing students, medical students, and we do this lecture, and this is the end of their break. So some questions to ask yourself when you're working with your population, okay? And you can substitute culture in for this. So have I considered the trauma this person experienced? Have you considered the cultural beliefs and customs of this person, right? Are you creating a safe place for this person to share? Do you have any unconscious or conscious bias? Or can you even be unbiased about certain things, right? How does your background, history, etc., impact your ability to serve the person before you? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And are you actively listening, or are you just talking or just listening to talk? Right. So if we think about these things and we think about improving health literacy in the context of everything we've discussed, these are things that you can ask yourself, to see, kind of like a check-in. All right, any questions, comments? Take a deep breath. Okay, everyone get up and stretch. We're actually going to resume in 5 minutes, if that's okay. We'll take a quick break. So 10:12, let's say. We'll resume at 10:12. And I will pause this. Okay, welcome back. The second part of this series is strategies to overcome vaccine hesitancy. There's two that we're going to review. We'll start with a real basic vaccine hesitancy definition. It's defined as a delay in acceptance or refusal of vaccines despite the availability, and it is one of the top threats to global health, and there are a few effective strategies. So, causes. These are the things that we've basically been talking about, a lot of them. Healthcare and socioeconomic inequity, lack of effective public health messaging, right? So the importance of clear, direct messaging. A history of unethical research. We know that that has caused a lot of mistrust in the system. Social disadvantages. These are social determinants. The growing spread of misinformation, disinformation, conspiracy theories, and then barriers to access, which isn't really an issue for us here in the United States. Okay, so I actually have to update this slide. I don't have the most up-to-date recommendations, so ignore this part on the left. But this is the new vaccine, right? So it's bivalent, meaning that it covers the original strain and the booster, or the Omicron, B4 and B5. Okay, so the CDC released this 12 strategies to improve the COVID vaccination rate. Two that we're going to discuss are motivational interviewing and combating misinformation. Motivational interviewing is amazing, and we're going to get started, and I'll pass it back to Maya.
Thank you. So every time I unmute, it gets a little loud, so I'm so sorry about that. So motivational interviewing is a guided style of communication that balances good listening with giving advice. It's designed to increase the patient's motivation and likelihood for behavioral uptake. And it's based on a respectful and curious way of being with people that facilitates the natural process of change and respects the patient's autonomy. Okay. So the spirit of motivational interviewing. So in this table, on the left side, it talks about motivational interviewing being a collaborative or a partnership between the patient and practitioner. And I'm sorry, I just lost my train of thought. And it honors, motivational interviewing honors, again, the patient's autonomy. Although the practitioner informs the patient on the clinical side, I like to say the patients are the experts of their situation. So of course, the practitioner may be the expert with the medication, but the patient is the expert on their specific life and their situation. So on the right side, it talks about the authoritative way, or the old school way of working or interviewing a client, or I'm sorry, speaking with a patient or a member. That's rooted in confrontation, or the practitioner knows best. And the education side, where the patient is presumed to have a lack of insight and knowledge, the skills required to change, and that the practitioner has the authority over the patient, and the practitioner knows best. Okay. So we want to talk about OARS. So OARS is an acronym for open-ended. So it's asking those open-ended questions that say, for example, you'd say, okay, so tell me more about this, or make this clear. So those are the open-ended questions. It's the affirmations, or recognizing and reinforcing success, being sincere with the person served. That sincerity does come across. If you're not sincere, it's very easy to tell. And being sincere does strengthen the relationship between CHW or practitioner and patient. Okay, so reflections mirror what the patient or the client is saying. So I know that we talked about this before, using their own words, or using examples like, okay, it sounds like, or it seems that, those buzzwords. And summarize, let the client, that's letting them know that you're listening. And at this point during the summary, you can clear up any unclear information. Okay, so motivational strategies to discuss COVID. I'm sorry, I don't want to okay, this is fine. Okay, start with an open-ended question and do not assume a vaccine acceptance. So that's a soft start to a very controversial topic. 2, acknowledge the patient's concerns without being judgmental. Empathy reduces the perception that you approve or disapprove of someone. Avoid criticizing the patient's information source. That information source could be a trusted person in their community, an elder. So try not to avoid that. Instead of criticizing, just provide factual information to combat that misinformation in a positive way. All right, so sorry, the 4th strategy, show awareness of your status as a messenger. This is especially important with our underserved communities and our communities of color. Who you are as a messenger does definitely matter. And link vaccine acceptance to the patient's hopes and goals, showing how or explaining how the vaccine can help them reach those goals can be very helpful. Okay. I'll pass it back over.
So we're going to do an example. I want to reiterate again, motivational interviewing takes a lot of work. It's practice. Once you learn the technique, it's hard to ask open-ended questions and have the patience, right? Over time, you get, because we're all time. We want to cut people off, but we have to let people talk. And so learning this style of communication to, kind of gather the information from the patient, understand their motivations, right? And then use that information to come up with a treatment plan that you're both, happy with. The patient's person-centered treatment plan. So we're going to do a quick example of motivational interviewing. And how we're going to do this is Maya and I will do 2 reenactments. The first one that we're going to do is based on the traditional approach of medicine, where the practitioner knows best, they're the expert, and the patient doesn't. So here we go. It's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles? This disease could be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccinations as he's already late according to schedule. We could do that now if you want.
Well, I don't see the urgency, and autism is way worse than measles. There's more problems and solutions with this vaccine. Moreover, it's completely unbelievable to give so many vaccines at the same time.
Studies have demonstrated there's no link between autism and measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you can find on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should update his vaccines now.
Well, I've heard something else, and not just on the internet. I do read a lot, and vaccines are not mandatory, so I can do what I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of disease is much higher than the risk of vaccine. If I'm taking this time to speak with you, it's because it's super important.
That's easy for you to say. Everything is so quick. But what if my son gets autism? I'm worried about the risk of vaccine, but you don't seem to care about the true risk of my child's health.
Of course I am. And I'm worried about the fact he could get diseases that could be prevented by vaccine.
Yeah, I don't think that we're on the same page. So let's just talk about this another time.
Okay, so I adopted the role of the expert and used a directive intervention approach based on argumentation and the writing reflex. So this led to an opposition. Okay, so we're going to go to another motivational interviewing approach and see how that goes. So Mrs. Campbell, what do you think about the advantages of vaccination?
Well, I know that the vaccine protects children against several diseases that we don't see anymore. My child received all of his first vaccines, but I'm worried about the measles vaccine specifically, that it could cause autism. For other vaccines, I have fewer doubts, but I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they are now much less frequent. It's why you vaccinated your baby, right? If I understood you correctly, with the exception of the measles vaccine, other vaccines seem safe to you?
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. You know, I read a lot of books and articles, and lots of people are worried about the link between measles vaccine and autism.
So you find that it's important to protect your child against diseases when the vaccines are safe, but you're worried about what you've heard regarding autism and measles vaccine. If you agree, I can give you some additional information on studies on autism and measles.
Sure, I want to know exactly what's happening.
In fact, you're right. One study had hypothesized a link between measles vaccine and autism, but this study was fake and the author lost his medical license. More than 500 additional studies around the world have demonstrated there's no link between autism and the measles vaccine. The frequency of autism is the same in the vaccinated group and then a non-vaccinated group. What do you think?
Well, so I'm not so crazy to be worried about that.
Of course not. You're totally right.
Well, thank you for taking the time to understand my concerns. I think it's a bit more clear now.
Okay. So in this example, I started with an open-ended question, summarized, did some affirmations, reflections, and it allowed the mother, Mrs. Campbell, in a non-judgmental way to express her concerns and her ambivalence. And, using this model allowed me to provide her with solicited information that she could accept. So this is just an example. Any feedback, comments? Oh, Robert, you're muted.
Okay, yes, in both examples, you using motivational interviewing, but in the second example, you was less direct, to kind of give her, a chance to kind of see which, to listen to the information and kind of, see which way that she really wanted to go. Even though you are the expert on the first example, you was like more direct, letting her see that that I am the expert and this is, more direct and everything. But in the second example, it was even though it was motivational interviewing, it was less direct. So, you're right, motivational interviewing is really, really good. But the first example was more direct. The second example was less direct, but both of them was motivational interviewing.
Well, the first one was supposed to be an example of the traditional, right? So way of working. So I'm telling, right? I'm the expert, I'm telling you.
Right.
Versus I may have the information, but you're a human and allowed to have some say in your own care, right? So let's get the information from you and work together to come up with a treatment plan. Yep, absolutely. Very good. Thank you, Mr. Quick, for sharing.
Yes.
All right, again, please follow up if you haven't ever heard this before. You need more YouTube videos. Who knows the difference between misinformation and disinformation? We're going to move on. Does anyone want to take a stab? Okay, so we've had both, right? We have a lot. Misinformation is not correct information, but it gets shared kind of like a mistake almost. People don't intentionally know that it's not true. They just share it because they think it's true.
Okay.
Disinformation is when people purposefully share incorrect information and trying to persuade people to change their mind, right? And so, we know what the role of social media and just all the media in general, right? There's a lot of information out there. When we were growing up, there was a newspaper and an encyclopedia. Now you can go to any website, right, and find stuff. So let's talk about just the role of social media very quickly, and then the importance of trusted messengers. Okay, so this slide is just an example of what kind of social media world we're living in. It's easy to understand how people have different understanding of information when you're looking at all these different sources, right? So that's something to keep in mind. Strategies for combating it, like Maya said earlier, with the vaccine, dissemination of factual and easy to understand information is the best way to combat misinformation or disinformation. Again, don't be judgmental, don't argue, just provide the factual information using credible sources. We've been giving this talk for a few months now, and in the past we've heard, well, what if the person doesn't believe the credible source is credible? There are people that think the CDC is up to something, right? Or whatnot. So that's a whole nother level that I don't have an answer for. And then again, like Maya said, we have celebrity, faith-based elders from the churches. We've seen them on TV. They've done a great job promoting the vaccine. Neighborhood champions. This was pulled in, this is from November, but we talk about, okay, you're going to use factual information to combat the misinformation. The factual information is here, people that were vaccinated were much less likely to be hospitalized for COVID. You can see here the green line is unvaccinated and the blue line is vaccinated. And then you can share the information. People are dying from COVID. Vaccination has decreased that risk. And we see that with our data. So just keep in mind that this is the factual information. Now, as COVID has now, of course, today is the end of the public health emergency. As COVID has mutated, it's become less virulent. It's not killing people as much anymore, which is a good thing in general. That was just a side note. Turn it over to Maya.
Thank you so much. Okay, so another one of our favorite parts, an interactive slide. So can anyone share a situation where someone refused to get the vaccine due to mis or disinformation? How did you react and was it effective? Does someone want to come off mute and share with us?
Or you can put it in the chat.
So during the height of COVID, I guess, I learned that the person who cut my hair was not going to get her daughter vaccinated because of what she heard, were the women's reproductive issues around the vaccine. And that, did I know that all these people were having miscarriages during that time? So the thing that I said to her, although I don't think it changed her mind, was that, do you know that 1 in 4 pregnancies ends in miscarriage? Nothing to do with COVID. And that was news to her. She had no idea. I'm not sure it changed her mind at all about her daughter getting vaccinated, but that was an interesting conversation.
Yeah, thank you for sharing. That was a great example.
Yes. Thank you so much. Yes, I agree. And you didn't argue or go back and forth. You just shared some factual information to combat that misinformation. So thank you so much.
Would anyone else like to share an example? Okay. We'll keep going. Okay, so it's 10:30. We're pretty much done. We have a quick, very quick case to go through. So we'll go ahead and do that and then wrap up. Okay, so this is Eliza. I'm going to read the case and then we'll just talk about it briefly. So Eliza is a 77-year-old woman. She's been diagnosed with long haul COVID. She experienced rapid heart rate, shortness of breath, and fatigue since she was hospitalized with COVID-19. So she sits in the doctor's office listening to the instructions in the treatment plan. And the doctor assumes she must know what he's talking about since she doesn't ask questions and tells her what she needs to do after a few instructions before her treatment begins. What the doctor doesn't know, because she's kept this a secret for as long as she can remember, is that Eliza does not know how to read because she dropped out of school when she was 8 to help with her family farm and never went back to learn. She has little medical background and barely knows anything about heart disease. He gives her pamphlets and written instructions that tell her everything she needs to know, but doesn't tell her much about what the papers say. He says to let him know if she has questions, and she responds with, "Okay, I will." Unfortunately, she can't read the material and is too embarrassed to admit she cannot read the information, which will lead to problems in continuing her health plan properly. All right. So thinking about Eliza sitting there at her doctor's appointment, what red flag behaviors did anyone recognize?
She didn't ask any questions. She said just okay when he gave her a brief rundown in the handouts.
Absolutely. What could have the doctor done differently?
Asked her to reiterate or to what's the word, the term used to teach back to her, repeat, what do you understand as to your plan that we've talked about? What is your role? What are you gonna do when you get home?
Absolutely. What about the handout?
Probably should have actually read through at least a little bit of it to her.
Yeah.
And might have gotten a better feel that she had literacy issues.
Yep, and Rosie wrote using the teach back method. Absolutely. Okay. So we're going to turn it over to Maya, or I'm going to turn it over.
Thank you. So in summary, our key takeaways, low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs as primary care, and increased mortality rates. All of these things do impact the quality of life. It's important to use universal precautions like we talked about and assume that everyone has low health literacy. Improving individual and community health literacy levels can reduce vaccine hesitancy and increase COVID-19 vaccination rates. So in a final review, the recommended grade level for all written material is 5th and 6th grade. Health literacy strategies can be used to increase the patient's understanding about their health condition, empower them to take an active role in their health. So we use things, some of the things that we discussed: peer communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation. Thanks.
All right, so thank you, everyone. Before we break, I just wanted to show everyone will get a copy of the slides as well as a link to this recording after this. There is CDC has a health literacy module that's pretty helpful. Also wanted to show the resources for some of the things we discussed. And if anyone wants to come off mute, any comments, questions, we welcome that. If you're able to, we would appreciate if you could participate in the post-session evaluation. You can scan this QR code, or Maya put the link in the chat box. When you're going to the post-session evaluation, you'll notice that there's an area to request a certificate of completion. So for those of you who are certified community health workers, you will receive 2 hours of CEU for Mishwa. If you would like, we're also offering a certificate in CEUs through Wayne County Community College District. In order to get that, you'll see after the evaluation, there's a section to put your name, phone number, address. Wayne County Community College needs that information in order to register you as a continuing ed student to do the education certificate. So if you're interested in receiving that, please fill out that information.
I've got a question.
Mm-hmm.
One of my tasks is what I call, or to schedule to confirm appointments, is sometimes or different calls that I have to make. We'll just cut to the chase. I have to discuss people getting the flu vaccine for their children as well as COVID. And because it's a telephone conversation, I am quickly shut down. I almost need like an elevator spiel on how to, shoot my best shot to these people, because sometimes I'll realize I may still be halfway about to catch my breath and they've hung up. Nope, not interested. Okay, but I'll see you to the appointment. Click. And I've been able to convince some people more on a one-on-one basis, but overall, what I've noticed in the pediatric sector is I've heard I'm not going to vaccinate my children because it's a high increased autism in Black males. Don't know where she got that one from. That was for COVID, not for MMR. So I was kind of surprised when I heard that one. But I don't feel that, I'm just be honest, I'm not very confident in some people's comments to have any type of rebuttal with them, because they are so deeply seated in what they say, and I don't want it to be combative. So I don't know how we can effectively
Engage.
yeah, that's the word.
The phone is going to be hard, Donna. You're going to have so much more luck one-on-one, in person, or maybe using technology. If you can send a text link with, here's more info, maybe make a flyer. I don't know. Maya, you might have better ideas.
Yeah, so thank you, first of all, for asking this question. This is a great question. And I agree with Dr. Custer. It is very difficult to make that connection over the phone. However, I will say at times the phone can be the best place to make that connection. So I would say be genuine in your responses, listen empathetically. So if you do get the parent that says, I don't want to do that because there's not enough research, just know your information. And, like we talked about, don't talk down on any information that they may have, your response. Okay, I definitely understand. So lead with empathy. I definitely understand. But I would like to share with you, if I could I email you some information that you could maybe go over? Can I text you this information? Can we just take a couple minutes to talk about some statistics? And then after that, if you don't want to move forward, I understand, but I just want you to make an informed decision. So it really is a combination of a lot of things, and it's going to be difficult. The phone, people can't see you. They don't see your, your eyes, your facial expression. So it will be hard, but I would say just keep trying and continue to reach out, because that helps build those relationships.
Does anyone else have an experience that they'd like to share about engaging on the phone? Oh, Mr. Quick?
I agree with Ms. Burrell. I work here in the clinic, and for instance, it'd be like 2 doctors on Monday, 2 doctors on Tuesday, 2 doctors on Wednesday. It's different doctors every day, also residents. So when I answer the phone, you trying to help the member of the patient the best way you can. And the first thing they say is, oh, I called my pharmacy and the doctor, he didn't send my medication. Then when I came back up there, I had to see another doctor, and y'all got different doctors up here. Unlike, okay, for instance, when I go to my primary care physician, I've been seeing her for maybe like 6, 7 years. So a lot of members, when they come here, they see one doctor, but then when they come back, they see, and that's kind of, to me, the frustration I hear on the phone. And like Ms. Campbell said, I'm having empathy. I'm talking to them, but they, a lot of older people, I would say the older people, like the senior citizens, they are more compassionate with me, like Mr. Quick, they talking to me and stuff. But maybe the people probably 40 years younger, they are, hollering, screaming, cussing, and but it's I see that's the frustration right there. they say when they come to the clinic, they seeing a different doctor. So by you being a doctor, I would like to, how should I handle that?
That's a tough one because you're in a training site, right?
Yes, yes.
You know, you could work, it would be more of like working internally with your people, right? Your staff and your leadership.
Okay,
Try to figure out a way to assign a provider, and then every time that patient comes, they see that provider. Now, I know the residents switch month to month,
right.
but even if you were able to have them see the same person during that block, that might be helpful.
Okay.
But that's a tough one. You know, you have to be very open about the fact that you're a training site when you're talking with patients, so they understand what they're actually receiving. Maya, I saw you nodding your head. Do you want to?
Yes,
Oh.
these questions today are
Yes.
like on fire. I'm sorry, Mr. Quick, go ahead.
Oh, no. Go ahead.
Okay, yeah, so I agree with Dr. Custard. Just setting those proper expectations right up front. So the reality of it is, you know, sometimes in some clinical settings, patients will see multiple providers. That's just, you know, the nature of how it goes.
Yes.
But setting those proper expectations from the very first appointment. I would go in and introduce myself because as a CHW, I'm the consistent person in the office. So even if the provider is different Monday through Friday, they know my face. I never met a stranger. I'm not shy whatsoever. I go in, introduce myself. Hi, I'm Maya. I'm your community health worker. I'm here to answer any questions. You'll probably get a call from me if I don't see you. So I'm setting that right away and also letting the patient know, hey, we provide quality service, but we are a testing or a training site. So when you return, you may see a different provider, same high quality of service, but it may be a different person. But I'm here as your community health worker. So if you have any questions, please feel free to reach out to me. And I would always introduce myself as Maya. And I, you know, and just build that relationship with the patient.
I like that, Ms. Campbell. I like that.
Thank you for sharing that, Maya. All right. Does anyone else? Oh, thank you, Rosalia. She says that is perfectly said, Ms. Campbell.
Yes, it was.
Thank you.
I think one of the, we can go ahead and stop recording now. You can go ahead and